Okay, Ryan. So the lecture will be recorded, so they can view it later on. And I'm just going to a quick introduction about who you are, and then you can take it over from. So for all the listener on this talk, Dr. Ryan Saab, he's an emergency room physician, and he's with us. I've known him for several years at St. Joseph Mercy, Oakland. We're in an inner city, and our hospital is level 2 trauma. So this is, if you know what a level are, we have designation by the American College of Surgeons, and that will qualify each center, to be a level 1, 2, or 3. And this is based on the services that are rendered and the specialties that are available, and the amount of research. So the difference between level 1 is that's the highest designation, is that there's a research going on at the same time. Level 2 and level 1, they basically provide the same services, and that's where we are. So we deal with a lot of traumas, from blunt to gunshot wounds to, of course, all the medical. And Dr. Saab today is going to tell us a little bit about the blunt trauma. You can take it over, Brian. And if you want to add anything, feel free. Again, for everybody, we will have kind of like a question and answer at the end of the session. So if you want anything, write it down, and we'll address it towards that. Go ahead.
Okay, thank you, Dr. Carmel, and thank you to all the participants who came out for today's informative lecture on chest trauma. Today, we will talk about both blunt and penetrating treating chest trauma. Just to give you guys a little bit of information about myself, my name is Ryan Saab. I'm a first-generation Lebanese immigrant. My parents came from Lebanon in the late 60s, early 70s during the Civil War. I have lived in Michigan and the United States my entire life. I've been back to the Middle East one time. It was beautiful. And I'm hoping to go back one day. I understand a lot of you are overseas right now. And so hopefully this lecture is informative for everybody. Currently, I'm the vice chair of the emergency department at Trinity Health, Oakland. And I've been with Trinity Health for about 8 years now. So I did my training before this at Wayne State University and St. John Medical Center in Detroit on the east side. And I know that you guys aren't familiar with the location, but the east side of Detroit is has a lot of trauma and lower socioeconomic status at that location. So got to see a wide variety of pathology and a wide variety of trauma. I met my wife in undergraduate studies at Wayne State, and we got married right before I started my residency. And a lot of times we were so busy, the only time she would ever want to hang out with me was to watch this show. And I don't know if you guys are familiar with it, but it's a very popular show back in the day called Grey's Anatomy. And it was a show about medical students, residents, and attendings, and how they worked in the hospitals and various things. And one episode that came to mind was a time in which there was somebody that came into the emergency department. And on this show in particular, it's basically surgeons that run the emergency department. I know it's different at every location and depending on where you're living, but so the person in this specific episode required an emergency thoracotomy because they were shot in the chest, and they required a cardiac massage. And at that time, I'll never forget, because my wife looked at me and said, "Oh, that's so cool. Do you do that too?" And I said, "Well, not always. It's not very common." And if something like that happens, usually the surgeons are there to help us. And her response was, well, why didn't you become a surgeon? And I just looked at her and said, well, I'm an emergency doctor. I don't need to become a surgeon. So she just so happened, and then that was that, right? I was really upset about what she said, and I just kind of went to bed right after. So um, it just so happened that she was rotating as a medical student at that time. Uh, and she worked with me the next day. And the next day, a gunshot wound came in. And of course, literally, it happened 3 or 4 times my entire career. That patient required an emergency thoracotomy. And we'll talk more about how to do it and what it's like later on in the presentation. And it just so happened that the surgeons were on their in-service or something like that, so didn't show up to the emergency department that time on time. So guess who got stuck doing the emergency thoracotomy? Me. So, and my wife got to sit there in the background and watch it all, and I was beating the heart with my hands. And never in my life did I ever want to be a surgeon until that moment in time. So I just thought that was a very interesting story that I wanted to share with you guys. Hopefully, it's a good icebreaker for you, for everyone on. So these are all of the, and if this is a little bit too small, I do apologize, but you should be able to zoom in on whatever device you're using, whether it be your phone or laptop. These are all of the possible injuries of the chest once there's blunt or penetrating trauma. I won't go through all of these because each one of these could be a lecture in and of itself. We'll just choose some of the most common. And thoracic trauma accounts for about, in America right now, 25% of all civilian deaths. If it's just one specific isolated organ, the mortality is about 5%. But most commonly, as you know, it's multi-system, meaning it involves more than one of these organs. And when that does occur, the mortality jumps up to 33% here. So just for the sake of learning, we'll take a few different type of injuries and pretend that it's isolated, talk a little bit about the pathology, how to diagnose it, pathophysiology, and the management. So we'll go ahead and start with the first organ, cardiac, and we'll talk about the differences between blunt versus penetrating cardiac trauma, the pathophysiology about why this occurs, how to diagnose it, and how to manage it. We'll go through some videos and we'll go through some cases. I'll try and keep it somewhat basic and then somewhat informative for the physicians on the call. And if there's medical students as well, hopefully this will be informative for you too. So let's start out with penetrating trauma, cardiac trauma. These are all of the potential wounds of the heart that can hurt, that can be injured with a wound ballistic. So you can damage the pericardium, the myocardium, any of the valves, the coronary arteries, and then obviously rhythm disturbances. This square here is a diagram that is identified something called the cardiac box, which is the area of most common injury with penetrating cardiac trauma. This cardiac box is bounded by the sternal notch superiorly, right here, sorry, the xiphoid process, and the nipples. So the greatest risk for injury in this area is the ventricles because they're close proximity to the sternum. And the right ventricle is the most common injured. So let's see here. The reason that this can be catastrophic is obviously because of hemorrhage. Whenever there's penetration to the area where blood is flowing, obviously the hemorrhage and exsanguination are the biggest issues. So resuscitation is of utmost importance. The ventricles are the greatest risk, and the right ventricle is of the greatest risk, as we talked about. And something that we always get worried about is cardiac tamponade. And what that is basically when there's fluid or blood in this case that accumulates in the pericardium, the sac that holds the heart. So why that's a big deal is because when blood accumulates in that sac, you get an increase in the intrapericardial pressure. And then when that happens, you get a decrease filling of the ventricles, and then therefore decreased cardiac output, hypotension, and potentially even death. To diagnose a cardiac tamponade, the most common and thing you'd see in the books is something called Beck's triad, which is hypotension, muffled heart sounds, and JBD. However, as I'm sure many of you know, it's very difficult to diagnose that, especially in a loud resuscitation room with multiple people there. Usually what you'll see is have a high clinical index of suspicion, sinus tachycardia, hypotension, with a penetrating wound to the heart or to the chest wall. So let's go over a few cases. So here we have something called ATLS protocol. And what that is a standardized way in which we resuscitate trauma patients. And basically we go through multiple steps in order to make sure things aren't missed. And we address the most concerning things first in order to ensure that the patients are well taken care of. There's
Let me just
sure.
So ATLS, it just stands for Advanced Trauma Life Support protocol. So that's what ATLS is. Thank you.
Yes, of course. So Advanced Trauma Life Support protocol. Sorry, I was getting a phone call. And it's a series of steps similar to what you would do. I'm sure that you guys have heard of ACLS, Advanced Cardiac Protocol, Life Support Protocol. It's similar to that, but it pertains to trauma. And back in the day, this was actually invented, I think it was an orthopedic surgeon who and his family member had a trauma in a different state, and went to a hospital and noticed that there was chaos and no standardized way of doing it. So he developed this protocol in which we go through A, B, C, D, E, and then airway, breathing, circulation, GCS, exposure, and we do a primary survey. And then afterwards, we do a secondary survey with a full physical exam, adjuncts, and imaging. So that way we don't miss anything. But there's entire lectures on that. But just to give you an idea of how it works here is that usually people would come in via EMS. Sometimes they do walk in, but this specific case was a 33-year-old male that got into an argument with his girlfriend and got stabbed in the chest. And you get an EMS call. Usually the EMS will call you ahead of time and give you an initial set of vitals, and that they're transporting the patient over. And they've been give you just a quick rundown. The patient was stabbed in the chest. They have an obvious wound to the center of their chest. The patient arrives, and you go through your advanced trauma life support protocol, the ATLS protocol, starting with the airway, the patient speaking, and everything is looking normal. Their blood pressure and vital signs are good. And you continue with the workup and management. In this specific situation, the patient came in alive and was talking. The blood pressure was normal. And all of a sudden, the patient's blood pressure plummeted in the emergency department, became hypotensive, unresponsive, and required an ED thoracotomy. During that time, it was found that the patient had a laceration to the pericardium, leading to hemorrhage, and it required repair, and the patient was admitted to the ICU. We'll talk a little bit about each one of these things in a little bit. At the same time, you get a 33-year-old female that came in with chest pain. She was actually the girlfriend of the boyfriend that was stabbed. So she was driving about 75 miles an hour on the highway and lost control of her car and crashed into another car. Her main complaint was chest pain. So she arrived, otherwise healthy, 33-year-old female, and she was resuscitated via ATLS protocol. We put her on the monitor and we saw this atrial fibrillation. Very unusual for this type of patient. So highest on the differential would be something like blunt cardiac trauma. So these patients usually require monitoring and further observation in the hospital. Let's get into this a little bit more. Let's start with blunt cardiac trauma. So let's see here. Some of these are a little bit hard to read. I do apologize, but just try and zoom in here. So there's a lot of mechanisms of injury for blunt cardiac trauma. Most commonly is direct impact. You can have a deceleration injury or any type of blast injury from a bomb nearby. These are all of the potential associated injuries with blunt cardiac trauma. Keep in mind, it's usually multi-system and not just one organ, but for the sake of learning, let's just consider it as one organ, and there's blunt cardiac trauma. So the biggest cause of or leading cause of death from blunt cardiac trauma would be complex arrhythmias. You can get cardiac free wall rupture, laceration to the coronary arteries, or even if it's big enough of a blunt cardiac trauma, you can get extracardiac hemorrhage. So if it's not as severe, usually the pathophysiology and the reasons that it causes hypotension or concern is because you can get the subendocardial hemorrhage, you can get focal edema of the myocardium because of this hemorrhage, and then it leads to further infiltration of PMNs and leukocytes and so on and so forth. Additionally, what can happen is once all this is going on, you can get coronary artery spasming and decreased blood flow, therefore. You can get dissection, you can get compression of the adjacent locations of the heart, and even because of this, a redistribution of blood flow and even ischemia. Sometimes what can happen too is you get intrapericardial blood that flow that builds up, and it leads to increase in the intrapericardial pressures. And when that happens, you'll get decreased ventricular output hypotension. So some high-risk characteristics of blunt cardiac trauma would be patients that are older in age, if you're greater than or equal to 60. If you're in the front seat, high-speed collision, and not wearing a seatbelt. Any type of deceleration injury could also be a high risk. To make the diagnosis of blunt cardiac trauma is very challenging because of it being a multi-system injury. Most commonly, what you would do is multiple diagnostic modalities. So usually in the resuscitation bay, you would start by placing the patient on the monitor, as we did in the previous example. Sometimes you'll see an arrhythmia. Commonly, the blunt cardiac trauma patients would have an arrhythmia, and if they're younger, usually it's unusual to see that. An EKG does not exclude blunt cardiac trauma, so you have to do multiple etiologies: cardiac monitoring, EKG, and an echocardiogram, serial troponins. And a troponin can be elevated secondary to the trauma, and because of the small amount of the necrosis of the myocardium, as I talked a little bit about before. Echocardiogram is helpful because you can look at all of the chambers and evaluate for wall motion abnormalities and the valvular function, and you can also address the ejection fraction at the same time. The only universal accepted practice to diagnose a blunt cardiac trauma is actually observation, though. And during this observation period, all of these are monitored at the same time. And usually the patients are just managed supportively and treat the initial causative concern. So we can talk a little bit about management of cardiac trauma. I did talk just briefly about blunt, but we'll talk about penetrating trauma as well. There was that one earlier that we talked about where that female stabbed her boyfriend and led to an ED thoracotomy. So we'll talk a little bit about that as well. So in the emergency room, it's unusual, but it does occur, and there's some specific indications for an emergency room thoracotomy. Obviously, the preferred method of a thoracotomy is in a controlled environment, such as the operating room. However, there's certain situations in which it has to be done emergently. And if it is done emergently and correctly, if it's just an isolated wound to the chest, then the survival rate for stab wounds that are going to go to the operating room is about 70 to 80%. But gunshot wounds, it drops to about 30%. And the reason is logically, stab wound, usually at just one spot. But if it's a wound ballistic, for example, it can go from the heart, hit the lung, and multiple vessels on the way. So I briefly touched base on the indication to do it. Not everyone that comes into the emergency department with a penetrating chest wound gets an ED thoracotomy. No. The people that might be candidates are patients that come into the emergency department with demonstrated signs of life at the scene where it occurred, en route via EMS or in the emergency department. And what I mean by demonstrated signs of life, a palpable pulse, a blood pressure, pupils are reactive, they have purposeful movement, they had some monitoring on the cardiac monitor, or they have respiratory effort. And then suddenly they decompensate and they deteriorate, they become hypotensive and unresponsive. Usually that's an indication of there was a hemorrhage that occurred in the area of the penetrating trauma. Another indication would be if a person had a chest tube inserted, for example, and they had rapid exsanguination of a significant amount of blood from that chest tube. There's no absolute contraindications to the emergency thoracotomy, but a relative contraindication would be severe head injury, severe multi-system trauma, or a blunt cardiac injury without cardiac activity. I'm going to show you guys a couple videos. I hope that they work with the Zoom. I'm not sure if they will or will not, but they're both couple 2 to 3 minutes. It basically goes through the thoracotomy, but and I can speak a little bit through it, but long story short, if they meet the indication, what happens is we make a U-shaped laceration through the skin, fat, all the way down to the bone on the left side. Use the rib cutters to cut through the ribs, and then we use a rib spreader to open up the cavity. We identify the phrenic nerve, open up the pericardium, evacuate any blood clots, see if there's any holes or lacerations that can be quickly repaired, and then we potentially cross-clamp the aorta. So let's see if, I hope that these work. So bear with me here for a second. Can you guys still see my screen or no?
We can see the screen, but there's no movie yet. It's just a slide.
Okay, let me see if, so first I'm gonna fast forward this to here.
Along the rib.
Okay,
Probably because it opened another browser. This is not embedded into the presentation.
yeah,
So
I got it
someone-
right here. I got it right here. You guys got this right now?
Now we can see this.
Okay, yeah, I'll toggle back and forth and I'll make it a little bit larger if you guys need. But basically what this is a quick ED thoracotomy on a cadaver.
And again, the scissors is going to.
So what happens here is, I'll let them talk through it, but this is just an example of a resuscitative ED thoracotomy.
Through the skin, now we're going through the adipose tissue and the serratus muscles. You're doing a few more.
We can't see the actual movie, just the screen is static. We see your cursor, but not the movie.
Okay, let me try this. Let's try this. Can you guys see this now?
We see the screen.
Can you see the movie?
It is not running, no.
Okay, I'm gonna run it right now. So the initial part was just the incision. We don't gotta
Accurate
watch
line,
that.
but still.
Yes, we can see it, yeah.
Okay, so the initial part was just the incision. I don't need to repeat that again, but you can see here he's making a U-shape incision.
Now with the scissors, cut down through the intercostal space. Be a little careful doing that with your finger with rib fractures. It can happen. Penetrating trauma, not so much. Please notice the position of the rib spreader.
And the reason that he talks about the position of the rib spreader is you want it to be open at the top, just in case you have to go to the opposite side. Because if you have it flipped around, if you can imagine, you would not be able to access the opposite side.
Open up, and now you're going to have access to the heart. And of course, now this is in a cadaver, so we don't have all the blood that you would normally have pointing out the phrenic nerve. One thing we want to avoid, certainly, when we're opening the pericardium. Going to lift the pericardium. I find this to be a tricky thing to do, to actually lift, particularly with the blood. Lift the pericardium, make an incision. Again, if there's tamponade, it's going to pop out much more at you than a situation like this. Okay.
Okay, great. I think that you guys got to see kind of the idea of that. Let me go back to my PowerPoint and I will go back and forth if needed. I do have another video that shows more. You guys can see my PowerPoint again?
Yes.
Okay, great. I do have another video. If we have time, I can show it. It shows more of what happens in a real life thoracotomy when you open the pericardium and how the blood gushes out. So I can show that at the end if there's time permitting. So moving on, pulmonary contusion. So we'll also talk about the lungs, talk about why it's a big deal when they get injured and how to make that diagnosis and how to manage it as well. So what's the big deal if the lungs get a little bit of bruise on them? The big deal is that when you have direct injury to the lungs, whether it be because of a penetrating object or because of blunt trauma to the chest wall, you get extravasation of fluid from the uninjured lung to the injured lung. And that occurs most likely because there's a fall in the pulmonary vascular resistance and then increased blood flow to both lungs. And then because there's more fluid going to the opposite lung, you subsequently can get hypoxia. And that hypoxia occurs because of the leakage of the blood and fluid into the interstitium and also into the alveoli as well. So here's a case. So this is a 45-year-old male that was involved in a high-speed MVC, was not restrained, and he was complaining of chest pain. He arrives to the ED, complaining of some chest pain, was stable, and he's resuscitated via ATLS protocol. And you get this X-ray, and this is what you found. Commonly, what we do in the resuscitation bay in ATLS protocol is get chest X-rays, and this is one of the main reasons. So what you can see here is multiple infiltrates on one side of the chest wall, and with the clinical suspicion and clinical scenario, you can make the diagnosis of a pulmonary contusion. Technically, according to the books, usually it's an area of lung opacification within 6 hours of blunt trauma, and then you would consider that as a diagnosis of pulmonary contusion. Also, you can do a CAT scan, obviously, which is the preferred method, and you would see as well multiple areas of consolidation. Management relies on pain control. There's no exact 100% science. There's multiple levels of recommendations, but no level 1 recommendation. And basically, the idea is to provide pain control, provide them supplemental oxygenation, You can try non-invasive ventilation if they're hypoxic, and the last resort would be intubation. The key here is that studies have shown that steroids do not help, so don't give those. And be extra careful with fluids because, as discussed before, it can lead to further pulmonary edema and worsening of their clinical situation. Pneumothorax. So, excuse me, we'll talk some about a pneumothorax and how to make a diagnosis and how to manage them as well. So a pneumothorax is basically the lung is kind of like a balloon and something hit the lung and it caused that balloon to pop a little bit. And basically any collection of air or blood within the pleural cavity can reduce the vital capacity. It'll increase the intrathoracic pressures and decrease the minute ventilation. And when that occurs, you can get decreased venous return and subsequently hypoxia. So I hope these work. Okay, great. So to diagnose pneumothorax, most commonly what we do is a chest x-ray. You can also do more sensitive would be a CAT scan, but we can also do ultrasound as well. So here you can see that there's lack of lung marks on this chest x-ray. That would be a sign of pneumothorax. Here on the CT scan, you can see that the lung is down. This big black area right here is a sign of pneumothorax. We do utilize ultrasound as well in the emergency department. And it's hard to explain how we do it, but I can show you what the images look like. So this here, let me just press play. This is the normal, the way a normal lung will look. And you can see here when I put the ultrasound on the chest, you can see the two rib shadows. I'll play it again. Right here's a rib, and right here's a rib, and in between them are the lungs. And you'll notice that they're sliding, and that's considered normal. So there's no pneumothorax right there. I'll play it one more time for you. See the rib sliding, and that's normal. Okay. This is a person with a pneumothorax. So you can see here, they're breathing, they're taking breaths in and out, and there's no movement of the lung. There's a rib here and a rib shadow here, but the lung is not moving. So that's another way of diagnosing it. It's funny, I kind of jumped to the exam and the images. I'm sorry, I kind of jumped to the images as a way of diagnosing it, but it can also be diagnosed on history and physical examination. Very challenging though, because sometimes it could be small, but just keep it in the differential in patients that come in with chest pain, shortness of breath, or tachypnic. They have signs of trauma. And then on physical exam, you would appreciate decreased breath sounds, hyperresonance on percussion, or even if there's a lot of air, you feel the chest wall, you can feel the air, the crepitance of the chest wall. Okay. So we'll talk a little bit about the pneumothorax management. So there's multiple types of pneumothorax, tension being the most urgent, emergent, and a small pneumothorax and a moderate sized pneumothorax. The difference between a small and a moderate, usually like a small pneumothorax is one that's less than 2 centimeters from the pleural line to the apex, kind of like when you look on the CAT scan, you can see that. And then the moderate and large is greater than that. Tension pneumothorax would be a patient that has signs of a pneumothorax on physical exam, decreased breath sounds, muffled breath sounds, distended neck veins, but they also have hypotension and a movement of the mediastinum to the opposite side. And on exam, it's very hard to see, and sometimes it could be very subtle, but it would be more of the neck, kind of the trachea, the opposite way. If you suspect that there is a tension pneumothorax, it's life-threatening, they can decompensate immediately. So you would consider this in a patient that had deviation of their trachea to the opposite side, decreased breath sounds on one side, and hypotension in the setting of trauma. What you would do is something called a needle thoracotomy. And what that needle thoracotomy is basically you're just opening up that space, allowing some of that air to escape. So therefore you can decrease some of that pressure, allow for the lung to expand again, give you a little bit of time until you would put in a chest tube. So this is just a 2-minute video here. I'll try and fast forward it to the relevant parts. This is what a needle thoracotomy should look like.
We're going to be talking about in these circumstances. It's going to be that patient with tension physiology or a PEA arrest in whom you're treating a presumed tension pneumothorax as a cause of their arrest. Now, you do have a couple options available to you. One is catheter selection. Now, you have likely a 10 gauge on your person, as well as in the black bag. And you also have 14 gauge angiocaths. And you'll notice that the difference is not just the internal diameter. Obviously, the 10 gauge is larger, but the 10 gauge also is much longer. So it is a 3-inch catheter, whereas the 14 gauge, as you can see there, is a 1.75-inch catheter. Now, for a normal individual, 1.75 inch may be sufficient to access the thoracic cavity, but in a larger individual, the 3-inch angiocath may be required. Apart from catheter selection, you're also going to have site selection. So depending on the studies you believe, whether you believe the ultrasound models or the CT models or the cadaveric models, you can choose a 4th or 5th intercostal space, which is the typical location for tube thoracostomy, or you can choose the 2nd intercostal space in the mid-clavicular line. We're going to describe here a little bit more fully is that 2nd clavicular space in the mid-clavicular line. You'll see Dr. Hinckley here is sort of marching out along the clavicle. And after he's identified the full length of the clavicle, he's going to identify the midpoint. And then he's going to march down with his fingers and find the 2nd intercostal space. And this is kind of where he's going to target his catheter at a 90-degree perpendicular direction to the skin surface. Let's see him do this in one smooth video here. You can see he's marching along the length of the clavicle. He's identifying the midsection. He's marching down to the 2nd intercostal space. Now taking his 10 gauge angiocath, removing the plastic catheter over top of it. And now inserting perpendicular to the skin. He's going to insert until he feels a rush of air. After he gets that rush of air, he's going to advance the catheter further into the thorax and then leave it in place. And that's all there is to the procedure.
Okay, great. Hopefully that sometimes the picture or video is worth 1,000 words. So let's go to this one. This is very similar to what we talked about before, but in this specific situation, the patient required a chest tube. Just for the sake of time, I'll play it, but I'm going to fast forward it. This is how we manage moderate to large pneumothoraces or even a hemothorax. So we'll talk a little bit about the hemothorax in a minute, but let's have you take a quick look at this video. Let's see if I can get it to play. So you prep the wall of the chest wall if you can, apply some local anesthesia.
Over the 5th rib, estimated at the nipple line, in the mid to anterior axillary line. Step 5, anesthetize the patient.
So this is a chest tube insertion that we would use, an example of how to do it. He's anesthetizing the chest wall.
Step 6, make a 2 to 3 centimeter transverse incision through the skin and subcutaneous tissue. Step 7, bluntly dissect through the intercostal muscle with a Kelly clamp. Advance the Kelly clamp over the rib and into the thoracic cavity.
And usually in an emergent situation, what we do is, you're not really blunt dissecting. You're just going in really fast, pushing really hard, and then expanding the Kelly clamp like they're doing right there.
Slide a finger over the clamp into the pleural cavity before removing the Kelly clamp. This finger remains in place until the chest tube enters the pleural cavity. Step 8. Insert the chest tube with the clamp through the tract created alongside the finger held in position. Advance posteriorly, medially, and superiorly. Be certain all fenestrations are well within the thoracic cavity. Step 9. Cut the flared end of the chest tube so that it will attach to the chest drainage system.
That's pretty much it for that. They go in on how to secure it and how to hook it up, but I don't think that we'll need to go through that today. So let's see. I don't think I talked about a little bit of hemothorax. Let me just try and go through this real quick. Okay, so this is actually just chest tube management, and this is like our management guidelines in terms of how to manage the chest tubes. It's just a good flow chart that helps us. I know it's very small, but I could send this to anyone if they were really interested. But basically, it talks about the management of chest tubes and when to consider cardiothoracic consultation in a setting of hemothorax or a pneumothorax, and it gives us a little bit of guidance on that. Hemothorax is when there's blood in the pleural cavity that can occur with chest trauma. We'll talk about why that's a big deal and how to diagnose this and manage it. So usually what happens in the hemothorax, there's a large amount of clots that go into the pleural space. And then what happens is those clots can release like small anticoagulants because they release fibrinolysis. And when that happens, it leads to further bleeding, further clotting, and it can restrict the venous return and ventilation. And then you can get hypoxic because of that. So in massive hemothorax, it's life-threatening, obviously because of hypovolemia, because of hemorrhage. And when that occurs, you don't have enough volume to sufficiently or adequately allow for ventricular filling and adequate cardiac output. And then if it continues to hemorrhage, the collapsed lung can promote hypoxia because of the hypoventilation and the perfusion mismatches. And then when if there's a hydrostatic pressure that increases because the blood that's there, it's hard to have the venous return at the same time. And that further impairs the preload and cardiac output as well. So to diagnose the hemothorax is very challenging on physical exam, but it would be very similar as a pneumothorax. But what you would do is listen, and you would hear decreased or absent breath sounds. And if you percuss, it would be very dull. Massive hemothorax is diagnosed usually on imaging, or if you put in a chest tube and you get a significant amount of blood. Usually if you get greater than 1,500 mLs of blood immediately afterwards, or 200 mLs of blood per hour for 4 hours straight, that's usually an indication for surgical exploration and surgical management, because there's obviously something that's bleeding in there. So going back to another case of a 40-year-old came into the emergency department after they had a gunshot wound to the chest wall. They arrived to the ED with an obvious wound to the chest wall. ATLS protocol was initiated, and you diagnose them with a hemothorax, chest tubes inserted, and you get 1,500 mLs of blood out immediately. The patient would need surgical exploration. These are some helpful algorithms. Once again, I apologize, they're a little bit small, but it goes through how to manage a patient with a penetrating thoracic injury that's stable versus unstable. And once again, I could send these to Dr. Carmel if he wants to distribute those to you guys. And I think that's it. I left a little bit of time for questioning. I'll stop sharing my screen. I hope that was informative for everybody. I know it's a large variety of people joining. So thank you.
Brian, thank you very much. I mean, that was awesome. I mean, the illustration and the videos and all that, I'm sure it's very helpful and all that. Just in the chat room, and I'm not sure what the actual, Dr. Ahmed Wiyana, Ahmed Salman.
Yeah, you're looking at the chat. It says something
Yeah,
about
it
detecting the
says,
size of the
How
air.
can you detect the sex? And I
Yes.
don't know really what it meant, but go ahead if you have a comment.
I think what they might be questioning is the difference between the moderate and a small pneumothorax. So in radiology, what you can do is there's measurement tools in the computer, and you measure from the top of the lung, you can see in the top of the pleural cavity. So keep in mind the pleural cavity sits a lot of things, obviously. So you got your heart, your lungs, esophagus, all the large vessels. So in the, let's say on one side, the lung is down some, there'll be a small gap where you can see that there's an area of black. And what we do is we measure it. And there's a tool on the computer that you can measure from one spot to the next, and that'll give you the measurement. So that will help you delineate between a small, moderate, or large.
Is there anybody in the audience who's in the trauma or emergency room or thoracic surgery or have experience with, chest trauma?
Hello, Doctor. This is Dr. Ali with you.
من عيني؟
Dr. Ali with you, emergency physician.
يا أهلا وسهلا.
Victoria. Doctors, I have a question regarding the measurement between the top of the lung to the, I think you mentioned that one during the radiological study. I remember there is another measurement from the hilum of the lung to the right side. I think in UK they use this guideline. So what do you think, or what is the most specific or sensitive one to follow, or there is no big difference? What do you say?
So honestly, I wasn't sure about looking from the hilum or not, but usually it's pretty symmetrical. With my experience, you see it coming down equal around the whole spot. So usually what we do is just measure from the top of the lung to the top of the pleural cavity, or if it's on the lateral end, just use the lateral portion. But I'm not sure of a difference, to tell you the truth.
And I'll just share, Ryan, I'll
large,
just share with you my, I'm a plastic surgeon, but I did full training in general surgery, including thoracic surgery and all that. From, my experience with that, the only difference that it makes is that do you need a chest tube, an emergent chest tube, or you can get away with observation and possible, repeat, and this may progress. So we can quantify the measurements and how big it is and all that. In reality, the management that is going to be impacted is that do you need the chest tube, urgently or emergently, or you can monitor. And usually the monitoring, it is rarely done with, almost never done with a penetrating trauma. And it's mostly done or considered to be done in a blunt trauma with, a fractured rib or sports injury. And that's where the measurements may become of value.
Yeah, of course. Thank you, Dr. Carmel. That's a very good point. Usually it's in the blunt situation, or for example, if someone not related to trauma, it's also related to people that have spontaneous pneumothoraces with like a bleb, for example. The chest tube insertion is a procedure, and whenever you do a procedure, there's chance and risk for complications. It's not just like easy, like they say in the videos or doing the videos. So if we can still have good patient outcomes with just providing supplemental oxygenation, then that's usually the preferred way, especially with a small pneumothorax.
My question to the people on the call, does anybody use the technique for the chest tube that was shown in the video, or you use the trocar to assist in the insertion of the chest tube?
From our place, I'm working in the UAE. we use this technique like in the videos. I just make an incision, then guide it with your fingers. The trocar, I think, just in our country in Iraq, they were use this one. Or sometimes guided through the procedure in the beginning, then try to increase the opening, something like that. But here in UAE, no, or this procedure like by your finger or your you are using the surgical device usually.
So you're saying you use the trocar to help insert? I'm sorry, I don't know if you heard me. Do you use the trocar to help insert the chest tube? I lost the.
Hello? Yes, sorry, there's some interruption in the connection.
Uh-huh.
Yeah, in trocar, no, we are not using it.
Okay, good.
In UAE, we are not using it.
Okay.
But in Iraq, because I work in Iraq, I was in Iraq. Yes, we are using in Iraq.
Yeah.
At that time.
And that's really because I use it in Iraq and I can do both. I just want to, it is a lot safer to go with this technique that is shown.
Yeah.
The problem with the trocar, if you're not careful enough, I mean, it's a very good technique if you're, really careful of how to use it. But if you're going to use it, you're either going to be careful not to penetrate through the diaphragm, because it is reported that you go through the diaphragm and you end up in the liver, obviously on the right side, and or you may penetrate the lung parenchyma if the lung is closer to the chest cavity.
Yeah, thanks for bringing that up, Dr. Carmel. It's a good point. So, and also, if you notice in the video, they inserted their finger to somewhat help create a little bit of a track. That can be dangerous at times, though. In penetrating trauma, what can happen is, let's say that the rib is broken, there can be a small fragment or sharp part of the rib. So it's very important to stay extra careful and, avoid going towards the diaphragm. You're going to want to go posterior and superior rather than that direction. So it's happened before, though, or else you wouldn't have brought it up. And I know I've seen it happen too.
Any other question to Dr. Saab? We have just a few more minutes with him before he needs to go to pick up his shift and help save some lives. إذا أي سؤال بالعربي أنا مستعد أترجم همين. إذا صعوبة باللغة الإنجليزية ما عندنا مانع. بس دكتور راين ويانا. Thanks, Ryan. I think everybody had a good time.
Okay. My pleasure, and I hope you guys all found this informative, and God bless you guys, okay?
Thank you, Ryan.
Thank you
very much. Okay. اوكي، يعني زينة حيدر، عندكم أي سؤال؟ أنا دكتور علياء موجودين على الخط.
أهلا دكتور.
يا أهلا.
عشت إيديكم المحاضرة اليوم كلش رائعة حلوة.
ممتاز.
ما أدري الأخوة الباقيين إذا عندهم سؤال الأخوة الباقيين.
إحنا حاضرين. أوكي. يبدو أن الكل.
الأسبوع الآخر شنو عندك؟
الأسبوع الجاي راح تكون المحاضرة على the research with quality measures or how to write and how to basically read an article. الدكتور واسمه علي خاكي جراح من أوريغون راح أزود لك المعلومات عنه، ونفس الموعد راح تكون نرجع الموعد للثلاثة يعني من الجمعة الجاية الجمعة اللي وراها.
تمام إن شاء الله.
والجمعة يعني والمحاضرة اللي بعدين وراها راح تكون يجوز موضوع غريب، بس هو substance abuse emergency department. ما أعرف إذا هذا أكو، بس راح يغطي كل من الكحول إلى المخدرات إلى كل شيء.
دكتور موضوع مهم هذا.
حلو.
بالنسبة للإمرجنسي ديفيجن عندنا يعني سب سبيشاليتي به موجود بأمريكا توكسيكولوجي.
فراح يكون يعني بعد جمعتين راح تكون الريسيرش، بعد جمعتين راح تكون هذا السبستانس ابيوز ونبقى بعد
بالتوفيق ان شاء الله. ان شاء الله.
يا اهلا وسهلا.
ان شاء الله. ممنونين يعني دكتور.
اوكي
شكرا جزيلا
يلا
على
يعني
الحضور.
هلا ممنون
هلا
ممنون.
هلا، مع السلامة.
الله.
شكرا.
Saturday,